My name is Roy Stein, and I'd like to welcome you to this introduction to motivational interviewing. To tell you just a little bit about myself, I'm a psychiatrist. I specialize in the treatment of addictive disorders, and I've been leading an outpatient substance abuse treatment program at the Durham VA for about 25 years now. During my years of leading this program, motivational interviewing has developed tremendously in terms of research and application to a variety of different settings. And it's really had a tremendous effect on my work with individual patients, my supervision of trainees, and really on the philosophy of our treatment program as a whole. And I'm pleased to be able to share some of that experience with you today. The things that I'd like to cover in this series are, first of all, some of the background, basic concepts and definitions of motivational interviewing. And then we're going to talk about something that we call motivational interviewing spirit, which is really at the core of what we're trying to do here. Then we'll move on in the second part into some of the basic communication skills and what we call the 4 processes of MI. That's really getting more into the practice of how one does this with a learner or with a person in treatment. And in the final session, we'll talk some about ethical considerations in applying MI and strategies and resources for learning more about this. A couple of comments on terminology during the presentation, because as I said, I'm an addiction psychiatrist and most of my work is with veterans who have psychiatric problems and addiction problems. So when I give you examples of change conversations, I will most often use examples that have to do with alcohol and drugs and smoking and things like that. But these same issues could be applied in a variety of other settings. The other thing is I will interchangeably use terms like client, patient, person, veteran. So I hope you understand that all of those mean essentially the same thing. And similarly, I might interchangeably use clinician, counselor, therapist, doctor, again, the person who's doing the motivational interviewing. That all kind of will be interchangeable. So I want to point out that the content, the concepts and main ideas of this presentation come pretty directly from the work of 2 psychologists, William Miller and Stephen Rolnick. And they have most recently published the 3rd edition of the book Motivational Interviewing. And so really what I'm doing today is giving you my presentation, my understanding and application of the work of these 2 people that really have pioneered the field over the last 30 years or so. So let's talk about the background. Where did motivational interviewing come from? We hear a lot about it now, and it didn't just come out of thin air. And I see it as representing the confluence of 2 major streams of thought and practice. One is Carl Rogers' person-centered, or some people might call it client-centered therapy. And the other is the area of scientific research on behavior change. And frankly, I'm sure that many of the listeners of this program are quite familiar with the work of Carl Rogers. He's had a tremendous influence on all kinds of counseling throughout the 20th century. It might be interesting to point out for this particular audience that Rogers was, I believe, the son of a Presbyterian minister and himself attended Union Theological Seminary in New York for 2 years before transitioning over into his studies in psychology. And although his work is certainly not overtly religious or spiritual in nature, I think one can sense some of that influence kind of at the core of his approach to working with people. Just something to keep in mind. So a few words about person-centered or client-centered therapy as Rogers would have practiced it. First of all, it assumes that there is an innate human tendency towards health, adaptation, maturation within all of us, that is there in us as human beings. The therapy is non-authoritarian in stance. It is not about an expert interpreting, guiding, directing, instructing. It's about creating an environment in which that healing and wholeness-oriented tendency can emerge from within the person. So another term that's often used about Rogers therapy is that it is non-directive. The main technique of Rogerian therapy is reflective listening. And the whole notion is that the therapist's job is to create this atmosphere in which the person will find their own answers that will emerge from within. The characteristics of an effective Rogerian or client-centered therapist are, first of all, congruence, meaning a kind of genuineness or honesty, being a real person in the room with your client. This does not mean that you engage in a lot of self-disclosure and talk about yourself and your personal life and your background. It means that you're real with the person in that encounter. At the absolute core is the necessity to be able to provide empathic understanding. That's kind of the key ingredient of Rogerian therapy. And the therapist needs to operate from a position of acceptance. And the term that Rogers introduced and is widely used is the concept of unconditional positive regard, an acceptance of the human being without conditions or judgment. It doesn't mean that you necessarily agree with all of their behaviors or the way they're living their life, but that you accept the person as they are. So what is the relationship between MI and Rogerian therapy? They're related, but they're not the same thing. Well, as I said, Rogers viewed his approach to therapy as truly non-directive. He was simply there to provide this accepting atmosphere in which the patient would find the solutions. However, Rogers was a very open-minded, rational, objective person, and he was willing to submit his work to objective evaluation by others. And research conducted by one of his graduate students and colleagues allowed them to actually carefully review recorded interviews of his work over many sessions with one of his patients. And they were able to demonstrate that Rogers was, in fact, subtly guiding his clients through what we might call selective reinforcement. He was showing more interest, more empathy, more reflective listening, more attention to certain types of statements that presumably reflected his notion of what it means to be healthy and well-adjusted, and other things he was kind of letting go by without as much attention. And when this was brought to Rogers' attention, he actually acknowledged, gee, I didn't think I was doing that. I was not intending to do that, but I can see that this review shows that it was going on. So essentially, he was unconsciously guiding his patients in the direction of what he understood to be health. Well, where MI really takes off from that and says we can provide this person-centered, humanistic, accepting, non-judgmental atmosphere in a very genuine way, and at the same time, deliberately, consciously, and strategically help guide the person towards a positive change. So that's the connection between the two. So let's talk now about the other strain that kind of flows into the development of MI, and roughly speaking, we can call that a scientific approach to behavior change. And there's several broad observations that I'd like to mention in that regard. The first is that people can make major changes naturally or spontaneously. And what I mean by spontaneously is without the intervention of helping professionals like you or me. That people can make a decision and carry out a big change in their life, and it doesn't have to be done with somebody else making it happen. That when we as professionals do intervene, the evidence shows that brief interventions that don't have to be a long course of therapy, but a few or even one key conversation with a helping professional may trigger an important change. So the brief interventions can be effective. One of the biggest observations that really shaped the development of MI is the finding that regardless of what brand of therapy you are practicing, what theoretical framework, whether you call yourself a psychoanalyst or a solution-focused therapist or behavior therapist, that what predicts successful change is counselor or therapist empathy. That is across the board, that seems to be the ingredient that makes the difference in whether the therapy is actually going to have the desired outcome. Another observation that's really key to MI is that when people are on the brink of change, that ambivalence is the norm. It's the rule, not the exception. It is not true that people come to the brink of change either being, quote, motivated or, quote, resistant or in denial, that those two polar opposites really are not what we see. That what we see is people have mixed feelings about change, and that we should expect that as what's going to be happening when we try to help somebody. So when we look at all this, we need to realize that the therapist is the catalyst. The therapist serves to trigger a change that is potential within the person, as opposed to directing or creating or mandating a change that was not going to be there. It's also observed that behavior change occurs in stages over time. It's not necessarily a black and white, all of a sudden thing. And finally, that behavior change, that motivation rather, is a dynamic quantity. It can go up or down, it fluctuates. And it can go up or down within a given session based on the interpersonal dynamics of that conversation. That depending on how I interact with my patient, I could take a position that actually would cause them to be more resistant to change, or if we handle the relationship differently, the likelihood of change could go up. So we've talked some about the background in terms of the Rogerian influence and the scientific behavior change research influence. Now, what exactly is MI? And again, here I've shared with you photos of Miller and Rolnick, just to remind you that these really are the primary architects of this approach, but there are many, many other people that have contributed to the research and practice and development. So Miller and Rolnick, in their 2013 text, offer three different definitions of motivational interviewing, kind of at different levels. They're all complementary, they don't contradict. The first one they call a layperson's definition. So if you have a friend or spouse or somebody who asks you about this program that you're doing right now, and they say, okay, I'm working on motivational interviewing, and they say, what's that? This might be a way to explain it in one sentence. So MI is a collaborative conversation style for strengthening a person's own motivation and commitment to change. So I've highlighted for you a couple of the key phrases in there. It's collaborative, it's conversational, it's not directive, and it's about the person's own motivation. So that implies that the motivation is already there within the person, and we're simply strengthening it. The next level of definition is a so-called practitioner's definition. That gets a little more technical, something you might share with a colleague who's asking about it. So a practitioner's definition is that this is a person-centered counseling style for addressing the common problem of ambivalence about change. So again, you see this concept derived from the research flowing into the definition of MI. But you also see the term person-centered, which is the Rogerian view. And finally, they give a little bit wordier, more detailed so-called technical definition that's getting into their understanding of the processes that are at work. So in this one, they call it a collaborative, goal-oriented style of communication with particular attention to the language of change. It is designed to strengthen personal motivation for and commitment to a specific goal by eliciting and exploring the person's own reasons for change within an atmosphere of acceptance and compassion. So we'll kind of elaborate on this technical definition. So they mentioned the emphasis on the language of change, and that's something that to do motivational interviewing, you find yourself paying a lot more attention to the nuances of how you communicate. And they describe three different communication styles that really exist within a continuum. They're not mutually exclusive, but they describe these styles as following, guiding, and directing. And then on this slide, we have some of the different verbs that might be associated with each of those styles of communication. And each of them has its place in helping professions. So if I were working with a person who's grieving over the loss of a spouse or a child, I would think that the verbs listed under following would make the most sense, and they're probably very familiar to many of you. To attend, to be with, to observe, to stay with, to understand, to value. On the other hand, if one of us was in a car accident and were severely injured and brought to the emergency room, I think what we would want from the emergency room physician would be a directing style. We would need somebody who is going to command, conduct, manage, order, prescribe, run, steer. That's what's going to be called for in that setting. The problem is, at least for us as medical professionals, is that most of our training is in these more acute settings where the directing style is emphasized. But when we're working with people about behavior change that's going to have to occur over time and is involved, let's say, in managing a chronic illness or chronic difficulties, the directing style just doesn't work particularly well. And so the notion is that MI primarily emphasizes the guiding style. And so some of the verbs that would describe that style of communication are accompany, arouse, as in arousing motivations or reasons for change, assist, collaborate, elicit, enlighten, kindle, again, as in kindling one's desire for change, motivate, offer, support. So keep in mind these different styles, and they each have their role to play. It's not that one is good or bad, but they fit in different aspects of counseling and behavior change. Another concept that I find kind of interesting in motivational interviewing is the notion of the writing reflex, which is something that in fact can get in the way of effective motivational interviewing. And what Miller and Rolnick mean by the writing reflex is our natural, well-intentioned, laudable desire to help people, but that can turn into a desire to fix things, to come in with the solution, to correct, to solve, to rescue. We see somebody in distress. We see somebody whose life is going in the wrong direction, and we feel that we know what they need to do to change it, and let's get in there and do it. Well, the problem with that is that if we're dealing with somebody who is very ambivalent, and we've already said that ambivalence is quite common, if I come in and start pushing in the direction of the change and the person feels two ways about it, I'm taking up the pro-change side, and often what will happen is the other person will take up the anti-change side because they're still struggling with both. And the classic response is the yes, but response. If I say, yes, you really do need to start exercising every day, it's very important for your health, a common response would be, I know that, but I get really tired at the end of the day and you don't understand how busy I am. So in fact, when that happens, I'm inducing the person I'm working with to start arguing against the change, which is exactly opposite of what I'd like to have happen. So to be successful in conducting motivational interviewing requires reining in the writing reflex. Another aspect in the definition that I want to highlight is the importance of having a specific goal. MI is about motivation and commitment to a specific goal, and we often call that the target behavior. So, and this is also where MI diverges from a pure client-centered approach, because once we're working with the person, at least once we get to a certain point, there needs to be some agreement about what it is we're working on and what we're trying to move towards, kind of a point on the horizon towards which we want to navigate. So in healthcare, there are many obvious, straightforward, uncontroversial target behaviors, and I've listed a few for you, such as stopping smoking, attending scheduled appointments for managing a chronic disease, taking medication as prescribed, cutting down or stopping alcohol or drug use, increasing one's exercise, improving one's diet. So these are all pretty straightforward target behaviors. But in their most recent edition, Miller and Rolnick suggest that there is room for broadening out what we might think of as an appropriate target behavior to things that are not so discrete, but maybe might be more internal and objective. So examples might be coming to acceptance of a difficult situation in life could be a target behavior, or forgiveness of someone that has wronged you could be a target behavior, or even just reaching a decision about something that you've been stuck on for a long time. It doesn't mean that we take a side on what the right answer is, but helping the person move towards resolution. So I'd say as time has gone on, they've broadened what would be considered a reasonable specific goal or target behavior. I now want to talk about a really central concept of motivational interviewing. This is the notion of the spirit of MI. And when we talk about this, we want to keep in mind that MI is fundamentally an attitude. It is a way of being with a person. It is most definitely not a bunch of tricks and techniques or a way to get people to do things they don't want to do. It is not intended to manipulate people. And Miller refers to this as the heart set or the mindset of MI. You really have to center yourself and put yourself in the right place mentally, emotionally, and perhaps spiritually to be with the person, to be effective and genuine with MI. He has also, in another metaphor, Miller points out that trying to do MI techniques without the true spirit is like having a song where you have the words but you've left the music out. It just does not come alive. So we're going to talk about the MI spirit, which they describe as having four major dimensions which come together. So the four elements of MI spirit include partnership, acceptance, evocation, and compassion. So we'll talk about those in turn. So partnership is self-explanatory, but you could contrast it with a model based on authority. There's a notion of coming together as equal human beings, but one is providing some guidance, but we're definitely collaborating. Now, something that we may run into is that people expect us to be the experts. They say, well, you are the expert. It's your job to tell me what I'm supposed to do. The problem is that often they don't do what we tell them to do, so that's why we take a different approach. So Rolnick has come up with a very thoughtful response to that, which is to point out that people are the experts on themselves and on their own lives. They absolutely know way more about what it is to be them than we could, as the professional, ever know. On the other hand, I, as the professional, also do have a type of expertise based on my education, training, and experience with other patients. So the goal of MI is to bring these two types of expertise together in a partnership. It's not one or the other. Another more concrete way to put it is if you're doing MI, you as the therapist should be doing less than half the talking. You're not lecturing and instructing. Another way to put it is that MI is done with a person, not to a person. When we're engaged in working with people around change, sometimes it turns into what can feel kind of like an exhausting struggle, as though we're wrestling with the patient to get them to do a particular thing, and they're just pushing back and pulling and tugging. And instead of that image or metaphor, what we're hoping for is something more like dancing with the patient. We're kind of moving together in parallel. One person may be leading, but there's a flow and a grace and a sense of moving in unison. So that's kind of what we're hoping for. The second dimension of MI Spirit is acceptance. And it's when we talk about acceptance that you can really feel the Rogerian experience. As I alluded to earlier, this means acceptance of the person. It does not necessarily mean that we approve or acquiesce with the status quo. If the person is actively using drugs or engaging in self-harm of some type, it doesn't mean that we agree with those behaviors, but that the person who's having those experiences, we are accepting. And then, just to keep things complicated, there are 4 elements of acceptance. So we're going to talk about those now. So they look at acceptance as being involved with absolute worth, autonomy, accurate empathy, and affirmation. So absolute worth, and this goes pretty much directly back to a definition or language from Rogers, is prizing the inherent worth and potential of every human being, regardless of their life circumstances or behavior. Rogers would sometimes refer to this as non-possessive caring or unconditional positive regard. It's clearly the opposite of judgment. Another element of acceptance is accurate empathy, which is defined in Miller and Rolnick as, quote, active interest in an attempt to understand the other's internal perspective, to see the world through her eyes. It is not the same as sympathy for, nor is it identification with, as in, I've had a very similar experience, let me tell you about it. It's really focusing on understanding the experience of the other. And it's obviously the opposite of imposing your own perspective. Another element of acceptance is autonomy, honoring and respecting each person's autonomy, his or her irrevocable right and capacity for self-direction. It's the opposite of coercion or control. And in reality, to acknowledge the person's autonomy is simply to relinquish a power that we never had in the first place. I, as a physician, or anyone as a counselor or pastor or any kind of helping professional, in fact, cannot decide for another person what they're going to do. And simply acknowledging the fact that they are the decision maker and not I can be freeing, and is as I've said, it's a power that we didn't ever have. The final element of acceptance is affirmation, an attitude of actively seeking and acknowledging the person's strengths, efforts, and values. One way to look at this is making the effort to see the glass as half full. I might say that sometimes in some situations, maybe you're having to see it as 1/8 full and focus on that. But because the person may have a lot of difficulties and challenges, but you can train yourself to notice those strengths, those efforts, those desires for change that can be pointed out. And this can be really powerful for people because certainly in helping professions such as where I work, we're dealing with people often who really do have a lot of difficulties and a lot of what could be considered failures and problems. And having a respected person simply acknowledge the reality that there are positive things about this person, that they do have strengths, that they are making efforts, can really have a strong effect and can really connect you much more closely with the individual. So we've talked about the 4 elements of acceptance, and now we'll move on to evocation as the third part of MI Spirit. So evocation is the drawing forth of these strengths, of the knowledge, of the ideas, the motivations from within the patient. And so you can contrast that with education or indoctrination. In those processes, we're putting ideas and information into the person, whereas in evocation, the emphasis is on drawing forth from the individual. So again, this goes right back to a Rogerian assumption that people have within themselves valuable knowledge, insights, motivations, solutions, and the goal is to bring those forth. The final element in the MI Spirit that was added actually in the most recent edition is the notion of compassion. And obviously we would all very much agree with and hope that we are providing compassion to our patients. They describe it as to actively promote the other's welfare, to give priority to the other's needs. Other terms that you might substitute for this in terms of how they're defining it are beneficence from the world of medical ethics or altruism. It's an attitude or an intention. It again goes back to that heart set or mindset. And I think one reason that Miller and Rolnick stress compassion as one of the core elements is that a person could use many of the other aspects of motivational interviewing, spirit, and techniques more for the purpose of sales or more to influence people to serve your needs or interests as opposed to their needs. And so this emphasis on caring for the welfare of the other, they felt was very important to highlight in the most recent edition.
Maybe to introduce myself, I'll just go through some of these initials after my name. RSCJ, I'm a religious of the Sacred Heart and have been for, more years than you've been alive, I think. What I value from that is our life has been rooted in prayer and meditation, and our goal is to make known the love of the heart of God, and I love being able to do that in the situation of chaplaincy. My PhD is in pastoral counseling, and I got it from Loyola in Baltimore. BCC, I'm a board-certified chaplain with the Association of Professional Chaplains, and I am a licensed clinical professional counselor, which I decided it's much easier to work in a hospital where there's other people to take care of people who are suicidal or homicidal. So I use the skills. I don't really practice that separately. And I am at Rush University Medical Center in Chicago. I'm chaplain on the psych units, and I do a lot of education for chaplains. Some of you may be aware that practicing evidence-based work in the field of chaplaincy is becoming much more important for 2 reasons. One is to improve our care, and the other reason is so that we can speak the same language as other people in the healthcare field and be professionals. That does not mean we take a cookbook and follow the cookbook that represents evidence, and that's all we do. Evidence-based practice includes our own judgment, but it just calls to awareness methods of working with people that have some evidence that they're effective and not just based on, well, the person who trained me told me this was a good idea. So that's what motivational interviewing is, one of those ways of practicing and working with people that does have a strong evidence base. Why in chaplaincy care? I think evidence-based practice is just a perfect fit with chaplaincy care. Chaplains come from backgrounds, theological backgrounds that respect the person as someone made in God's image and have a sense of the center of that person, whether we call it spirit, the soul, whatever we call it. And so when we're working with people, we're there meeting the whole person. We're not just meeting the body. Chaplains believe it's part of who we are. We believe in the value and the inner power of the person to grow and to choose. Motivational interviewing focuses on helping a person uncover decisions about choices they think they can accomplish. And we'll look at that just a tiny bit more in a minute. And helps the person move towards the choices. From early in our faith or spiritual traditions, and I'm talking really early, like even 1,000 years BC in the Hebrew scriptures, there are those who act as guides for discerning. So in a medical setting, that's the chaplain's role, to sit with people and help them discern, or part of the chaplain's role. Why not just continue being chaplains and forget this motivational interviewing bit? Well, what motivational interviewing does is it puts in a framework and articulates very clearly what the skills are that work well with patients in a variety of settings and seem to help people make decisions that might be difficult decisions. Even though it's something we already do, it gives us a framework and a language, and well, I personally think it can also help us enhance the work that we do. There are principles for motivational interviewing, and they're repeated at any kind of workshop you ever go to. So if you see this written here, you're going to see it written thousands of places. If you do YouTube, you'll find this on YouTube. But these are some of the principles for engaging the person that are promoted by motivational interviewing. You work with the person, and we'll look at that in more detail. In the second session, we'll look more at how do you develop a discrepancy between where the person is and what the person's thinking at the time and where they might need to go. If a person's having difficulty, you just stick with them where they are. You don't try and force a decision on them ahead of time. And motivational interviewing supports self-efficacy. Now you'll hear some more, because I know those are 4 things you've probably not heard of before. I kind of like the cartoon that I found for this particular slide. People know when we believe in them. That's absolutely true. You know, I work with psych patients all the time, and they know that I believe in them. They know I believe that they do have a place in themselves that's worthwhile, that's good. So engaging, this is the first step, and that's what we're going to look at during this session, engaging the person. They make a point in motivational interviewing that engaging a person is like, in making a decision, is like dancing with a person. When you dance, someone takes the lead, but then you follow with them, you go with them, you move where they go. You're not just letting them wander all over the place, but you're moving along with them. It's not wrestling. It's not using logic to talk persons into this is the best decision you could ever make. So it starts with a relationship. You know, you probably wouldn't be a chaplain if you didn't like establishing relationships with people. I think it helps to be very curious about the dilemma that the person is facing, not to have the answers, to be curious about the person themselves. What's going on with them? What's going on that I can't see? Motivational interviewing uses the acronym OARS as a reminder of how you best listen to a person. And we'll look at these in detail. Open-ended questions, affirming the person, using reflective listening, and summarizing. We won't have too much details on summarizing, but we'll look at the others. Before we look at this reflective listening and relationship with the person, I just want to point out 2 figures in the field of psychology. And motivational interviewing was developed by psychologists and is based on solid psychological principles. But one guy, he happens to have worked in Chicago, but it's also a way we train our chaplains at Rush, is Heinz Kohut, who talks about the need for people to have someone who mirrors them, someone who affirms them, someone who helps them develop a deeper sense in themselves, as well as a sense of safety. Heinz Kohut didn't come from any particular religious background. His biography is fascinating and worth reading. He was from a Jewish family in, I believe, Austria or Germany. Don't look it up because I don't want you to find out that I don't know everything. But it was a very complicated situation. But then he grew up in Chicago. At the end of his life, he did acknowledge that the unconditional love can provide the sense of mirroring, of listening, of being there with the person, and the sense of safety that people need psychologically. And even at the end of his life, for his funeral, he asked to have played A Mighty Fortress Is Our God. We don't know everything that was going on in him. He wasn't religious, but his theory of psychology certainly fits in with understanding the whole person in before God. Another person I just love, Albert Bandura, is a wonderful psychologist who, among other things, developed a sense of a person's need for self-efficacy, or the sense that a person has a sense of self-efficacy. I hope that children still hear the story about the little engine that could. It was burned into my brain. I think I can, I think I can. People will do what they think they can do. If a person has to face a decision or some kind of change in their life and they don't think they can do it, if they don't think they can make it through treatment for a condition, it's going to really hold them back. So self-efficacy theory is an important part of motivational interviewing because it tries to help pick up where the person is and help the person be where they are, articulate what they think they can do so that they can take the next steps. Now we're going to move into the realm of chaplaincy. Chaplains don't just sit around and meditate and have their own private wisdom. They're rooted in a shared wisdom of whatever their faith tradition is. And I really can only pretend to know the Hebrew scriptures from a Christian perspective. We have had Muslim interns at our hospital, so I know, and we do have an imam, so I know some quotes, and that's about it. And I certainly know the Christian scriptures. But these are two quotations I think that fit quite well what we do. The Lord sees not as man sees. Man looks at outward appearance, but the Lord looks at the heart. When we meet a patient, if I could ask you to put up your hands right now, and you could do that as long as you're in a private room and nobody will notice you, I think you probably would claim that you do see and look for the heart of the person that you're working with in the hospital or in an outpatient setting. And in the Muslim tradition, whoever believes in Allah, he, meaning Allah, guideth that person's heart. And Allah is knower of all things. So isn't it a wonderful job that we as chaplains are there to be with people at their heart and help them listen, not to guide them ourselves, but to help them listen to how the Lord or Allah, the divine, might be guiding them. Back to OARS then in this context. OARS, as a reminder, use open-ended questions, use affirmations, use reflective listening, and summarizing. So open-ended questions. Why an open-ended question? We'll look at some of these questions first, and then we'll step back a minute and look and reflect, what was the value of using an open-ended question? Well, you'll see examples. So I was a patient with a terminal illness, and these are real people. The chaplains I work with gave me examples of real people. So she has a terminal illness and has about a year to live. And she's trying to decide between her son or her daughter for her agent for durable power of attorney for health care. So a closed question. Who would be better, your son or your daughter? Olive has no choice. She's either supposed to answer my son or my daughter. You're not going to get much information out of Olive that way, and Olive isn't going to hear very much about what she's really thinking. So let's look at the second question, which is an open-ended question. Tell me what your concerns are if you ask your son to be your durable power of attorney for healthcare, your DPOA. So that's letting Olive articulate what her own issues are and what her worries are. Some people do that naturally. Some people think inside, but some people only know what they're thinking when they have a chance to say something out loud. And so what we're doing is we're helping a person articulate what's going on with them. And the third question I kind of like the best, but you know, any of these are worth trying. Any open questions worth trying, because the patients really are the ones in control and they will say what they want. Your question is not going to be the most important thing. Asking the question is. So the third one, I'm wondering what's hardest when you think about this. So that could give Olive a whole broad spectrum of concerns she might want to talk about if she's facing death and who's going to be the decision maker. And we don't know what they are, but open-ended questions can be a very rich way of starting with a patient. So now it's your turn to dialogue. And you're going to probably dialogue with a paper and pencil since you're doing this on a computer. So Howard is a 60-year-old patient with 3 adult children, and he's trying to decide whether or not to have a kidney transplant. So I'll give you a minute to reflect. So write a closed question. There are other people here in the room with me. I wonder if any of them want to provide a closed question to this dialogue. Anybody want to? You don't have to. A closed question for Howard is a 60-year-old patient with 3 adult children. He's trying to decide whether or not to have a kidney transplant. Do you want to throw out a closed question? You don't have to.
Do you want to have a kidney transplant or not?
Yes. Excellent. Closed. The guy has no choice. It's either a yes or no answer. Okay, I'll do the open-ended questions myself. Unless somebody wants to jump in, you can. But be sure, if you're doing this as part of the course, be sure you've tried yourself. And open-ended questions, I'm just making these up as I go along. I have not researched the perfect open-ended question. So they don't have to be perfect questions. Whatever you're doing, it does not have to be perfect. An open-ended question. Howard, what goes through your mind when you're thinking about having a kidney transplant? That's open-ended. It lets Howard say what he wants to say. This is just another one from a slightly different angle. Howard, what are your children thinking about your having a kidney transplant or not going ahead with one? What are your kids' thoughts? Open-ended questions. So Howard can talk about it. He can say out loud whatever concerns he might have about his children. You'll get an idea about if his children are ready for him to decide, you know, I've lived long enough. I'm not going to have a kidney transplant. So the open-ended question gives the patient an opportunity to say whatever they want, and it gives you the opportunity to hear and learn and listen quite a bit to the patient. And you're going to hold on to some of that information for later on when you use some of the other tools of motivational interviewing. Okay, or, that was the O of or, open-ended questions. Affirming. What affirming does for a person is it says, you know, like, people are kind of odd. A lot of people, I mean, all of us are kind of odd. A lot of us think we're not quite good enough. If this great chaplain of the world is coming to visit them, they might particularly feel they're not quite good enough. So people need to be reminded they are good, and that is how they're seen in God's eyes no matter what. So affirming helps the person have some sense of their own self-efficacy and have a sense of who they are. So this is Olive. If you remember Olive was trying to decide to whom she would give durable power of attorney for healthcare, her son or her daughter. So we've heard her talk about that through the open-ended questions. And now we want to affirm Olive as a person and help her be centered in herself as a person. So some ways to do it. These are just examples. They're not the absolute. This is not like statistics where there's exactly one answer. So these are some possibilities. I appreciate your taking time to work on this, even though you do not feel well. You know, if you've ever been in the hospital yourself, if you felt really good, you'd be at home, not in the hospital. You're tired. You don't want to do much. Another affirmation is just to say, this is not an easy choice. You know, you shouldn't be able to do this easily. Another, you're continuing to be a good mother by focusing on what's best for your children. Or a last one, something helped you to decide to carry through on treatment since you were first diagnosed. You've been able to keep your focus on others. So it's a reminder of some of the good things in her that she's doing. So this is your turn to your opportunity to write 2 affirmations for Howard. Howard's the one who's trying to decide whether or not he's going to have a kidney transplant, and he has 3 adult children. So 2 affirmations for Howard. So think a minute and write them down. Two affirmations for Howard. Howard, I'm really quite touched by the way you're willing to look at both possibilities of getting a transplant and of not getting a transplant and the consequences of that. Another possible affirmation for Howard. Howard, you seem to be a man who really trusts himself in terms of being able to struggle with really difficult decisions. So those are a couple of my affirmations. And as a reminder, whatever affirmations you wrote, they're fine. They're going to be good. I trust you at that. So we've been through O and A of ORs. Now we're moving on to the R part, reflective listening. And these might seem like really stupid things that we're doing, but I'm again going to invite you at the end of looking at reflective listening to sit down and try this with someone and see what it's like to have somebody really listen to you. Most of us, most people don't really listen. They jump in with their own experience and tell you, well, when I had my gallbladder removed, blah, blah, blah. So learning to really listen. So this is a woman who's had a stroke, and she says, her mother rather has had the stroke, and she said, I need to decide whether or not to let her receive a feeding tube. The simplest way, and if that's where you can start, that's a fine way to start, is simply repeating what the person has said. They're not going to punch you in the mouth. They will if that's what you do through the whole session, but they're not going to. They're going to be glad that you're stopping and picking up on what they're saying. So simply repeating, no changes. You need to decide whether or not your mother should receive a feeding tube. The person feels heard. The person might hear themselves. They just spoke out loud what was going on, and maybe they didn't even hear what they're saying, and now they hear what they're saying. So a slightly bit more complicated, but it's not complicated. It's really simply to just rephrase what the person said. Your mother needs artificial nutrition, and it's up to you to decide to allow it or not. You're just saying exactly what the patient said, but with slightly different words. It's just a little bit more sophisticated. My guess is many of you probably are already using these skills, but guess what? I've been a chaplain for a pretty long time and a counselor for a pretty long time, and it never hurts for me to stop and practice the skills that I'm very aware of, because you know, I kind of get into working with people and I stray. I don't stick to things that are helpful. So the third possibility is to paraphrase, and that's a little bit more sophisticated. Again, you probably do this already. And isn't it nice to know that chaplains are using evidence-based practice without even having been forced into it? So paraphrasing, you have to make a major choice about what medical decisions to make for your mother's loss of ability to eat. So that's just saying things, maybe putting the words in a different order. So I moved artificial nutrition towards the second part of the sentence, and I just used different words. Finally, and again, I'm pretty sure that you're already doing this, but just focus and practice your skills. Reflection of feeling, and I'll read what I said, but there's other possibilities. You feel lonely trying to make this major decision on your own. That might not at all be what the woman is feeling. I might be totally off. I might have missed it completely. You know what? That's fine. Because what I've done is I've given, either I have identified the feeling and so the woman feels heard, or by this point, the woman and I have some kind of relationship, and the woman can say, well, no, that's not really what I'm feeling. Here's what I am feeling. And so you get a better idea of where the person is. The woman gets to articulate what she's feeling, and she knows somebody cares. You know, I like the nurses at our hospital, and I think they're great. And I like the docs, but they don't always have time. They're trying to take care of medication and vital signs and all that kind of stuff. So you can sit and you can acknowledge the feelings that this poor woman's going through. So those are examples, and whatever you wrote, it's probably pretty good. If you have a friend and you want to check it out with a friend, let them tell you it's pretty good. Practicing listening skills, again, if you have somebody who's willing to do this, the chaplains at the APC, the Association of Professional Chaplains, found this very, very helpful to have someone listen, paraphrase, reflect feelings. It's kind of like they got into being the patient and they could see the impact. We don't usually, I mean, once in a while we see the impact on a patient, but we don't always know what's happening. So you'll get some, if you just think of a patient you've actually worked with, that will probably be easiest with you. And then the directions are pretty clear. You can follow through on this on your own, just to practice, because this is not the kind of thing that you simply read about and then you know it. The only way you are able to do this is by practicing these skills. There's not a lot of research about chaplains and what chaplains do and how people respond to chaplains. We need to develop a lot more of it, and we are on a roll at Rush trying to make that possible. But this is an article by Flannelly et al., published in 2009, so it's not too long ago, about patient satisfaction with chaplains. And he asked, one of the questions he asked the group asked patients was, what is important to you about what a chaplain does? And the answers people gave were, they really listen. That was at the top. They pray with you. They help you tap your inner strength. Isn't that some of what we've been talking about? That's who we are and that's what we do. So motivational interviewing is a perfect home for us as chaplains. It's what people want. It's what we're trained to do. There's one more case I want to look at. This was an actual and really very painful case. James was 35 years old and had been treated for GERD at another hospital for 9 months. He was no longer able to eat. We're a tertiary care hospital at Rush. We take on patients who don't respond to treatment at other hospitals. So he came to our hospital for surgery. His mother, Louise, these aren't the real names, by the way, in case you run into them somewhere in Chicago. So the surgeon met with the mother after surgery and said the patient had stomach cancer with only a few months to live. Now, her son couldn't have heard that because he was still under the anesthetic, so he doesn't know that yet. Louise had lost a 24-year-old son in a motorcycle accident 11 years ago, and the chaplain perceived her as emotionally fragile. She felt she was being punished by God. She did not want to tell her son he had cancer. The nurses were kind of mixed. Some thought she should tell him, some thought, well, she shouldn't really tell him. So At this point, what does Louise need from the chaplain? Well, before the mother has a chance to even stop and think about deciding, because the decision she has, the decision on the treatment team, and I suppose along with the mother, I guess she'd have to be part of that, or with the son, I guess, when he's out of the anesthetic, is to put him into palliative care. So the decision the mother really has to make is, does she want to tell her son about the cancer, or does she want to wait until the medical personnel tell her son that she has cancer? That's really the choice. But she's nowhere near ready for that yet. This woman and the chaplain working with her did this. She needs a lot of time to process the tremendous grief of having lost a son and now being told she's going to lose another son. Any one of those things are things that she might need to be followed on, and the son will be in the hospital for a little while recovering from the surgery that he's had. Feeling she's being punished by God. If that's something she raises, that needs to be listened to. She's at the point in terms of motivational interviewing of needing a lot of decision making. If after all that listening, if the chaplain can say, this is a horrible situation, and I'm terribly sorry about your son having cancer. You could choose to tell him yourself, but you really don't have to. You could choose to let the medical team tell him, and that's perfectly fine too. If you want to look at those choices, fine. If you want to just drop it and leave it to the medical team, that's fine too. You're dealing with a lot right now, Louise. So that's the introduction to looking at listening skills that are commonly used by chaplains, that are very necessary in terms of being able to move people towards the decisions that they might need to make. If you haven't listened with a person, if the person hasn't listened to themselves by your listening and reflecting back to them, they're not going to know what they think when it comes time for them to be making a decision. Well, they might have a friend outside or somebody else, but it's a very helpful part of going through helping a person look at decision making.